Welcome back to AMC Decoded. Today, we are tackling question number 5. This is a high-yield respiratory and emergency medicine topic that appears frequently on AMC Part 1 exam, USMLE exam, MRCP exam, or NEET exam. It will test not just your medical knowledge, but your ability to follow a strict diagnostic algorithm. Let's look at the clinical vignette. We have a 28-year-old female who presents to emergency department with a sudden onset shortness of breath and right-sided pleuritic chest pain that started 2 hours ago. She returned from a holiday in Europe 2 days ago. Her only medication is the combined oral contraceptive pill. Vital signs: temperature is 37, heart rate is 112, BP is 124/78, RR is 24, SpO2 is 92% on room air. On examination, her chest is clear to auscultation. There is tenderness and swelling noted in her right cuff, which measures 4 cm larger in the circumference than the left cuff. Now, the question is, what is the most appropriate next step in the management of this patient? Now, I want you to pause the video right now and lock in your answers. Ready? The answer is C. Request a CT Pulmonary Angiogram or CTPA. Let's try to decode this. This is a classic case of pulmonary embolism. Remember Virchow's Triad for thrombosis risk? Stasis. Our patient had a long flight. Hypercoagulable state. She was on OCPs as well as endothelial injury. Most pulmonary embolism starts as a DVT in the leg and migrate to the lungs. The symptoms we see, dyspnea, tachycardia, or pleuritic chest pain, are classic. But be careful, the full classic triad, including hemoptysis, is actually rare, and it is only seen in less than 20% of patients. So, how do we work this up? On an ECG, the most common finding is simply sinus tachycardia, which our patient had. You might remember the S1, Q3, and T3 pattern, which means deep S wave in lead 1, deep Q in lead 3, and inverted T in lead 3. I'll put an example over here. While it's a famous exam buzzword, it is actually quite specific and rare. Don't rely on it to rule out pulmonary embolism in or out. Chest x-rays are usually done to rule out other things like pneumonia or pneumothorax and are usually normal in pulmonary embolisms. This is the most important slide of the video. In the exam, you cannot just order tests randomly. You must risk stratify using the Wells criteria. To remember the scoring, use the mnemonic EDGE, where E stands for edema, A is for alternative diagnosis unlikely, which gives you 3 points each. Tachycardia, immobilization, and previous DVT will give you 1.5 points. And cancer and hemoptysis will give you 1 point each. Now, let's score our patient. She had clinical signs of DVT, so that's plus 3 points. Pulmonary embolism was more likely than the alternative diagnosis, so that's plus 3 points. She is tachycardic. Our patient has tachycardia, a pulse of 112. So yes, that's plus 1.5 point, a total score of 7.5. Now, here is the golden rule. If the score is above 4, pulmonary embolism is likely. You stop and go straight to CTPA. You do not do a D-dimer. You only order a D-dimer if the score is 4 or less, where pulmonary embolism is unlikely. And you just do D-dimer to rule pulmonary embolism out. Now, briefly on management. If the patient is hemodynamically stable, we start anticoagulation immediately, usually with lower molecular weight heparin or fondaparin-ox. For long term, we use a rivaroxaban or apixaban or warfarin. If the patient is unstable, that is an emergency requiring thrombolysis to bust the clot immediately, or embolectomy if thrombolysis fails or is contraindicated. So, back to our options. Why the answer CTPA and not the others? We'll look at option A, D-dimer. This is the classic exam trap. D-dimer is a screening test in a high-risk patient, such as our patient with Wells score of 7.5. A negative D-dimer is not reliable enough to send her home. You would have to scan her anyway. So, doing a D-dimer just wastes our time. Option B, aspirin. Aspirin is for acute coronary syndrome or heart attacks, as we call it, and not pulmonary embolism. The pathology here is a venous clot, which needs anticoagulants like heparin and not antiplatelets like aspirin. Chest X-ray. A chest X-ray cannot confirm pulmonary embolism. It is useful for ruling out pneumonia or pneumothorax, but it is not the definitive next step for the pulmonary embolism diagnosis. Option E, reassure and discharge with analgesia. Now, this is a fatal error. Discharging a hypoxic tachycardic patient without investigation? That is just negligence. So, looking at the case one last time. High risk score, hypoxia, DVT signs. The correct answer? Pulmonary embolism. What we do? Request a CTPA. That's it for today's video. I hope this helps you master the pulmonary embolism algorithm for your AMC, USMLE, MRCP, or NEET exam. If you found this video helpful, please like and subscribe to AMC Decoded. I'll see you in the next video.